Pyloric stenosis. Definition. Pyloric stenosis is a narrowing of the opening from the stomach to the first part of the small intestine, the pylorus. Symptoms include projectile vomiting without the presence of bile. This most often occurs after the baby is fed. The typical age that symptoms become obvious is 2 to 12 weeks old. Pyloric stenosis is characterized by hypertrophy of the circular muscle fibers of the pylorus, with a severe narrowing of the lumen. The pylorus is thickened to as much as twice its size, is elongated, and has a consistency resembling cartilage. As a result of this obstruction at the distal end of the stomach becomes dilated. Statistics and incidences. Infantile hypertrophic pyloric stenosis is more common in whites than Hispanics, blacks, or Asians. The incidence is 2.4 per 1,000 live births in whites, 1.8 in Hispanics, 0.7 in blacks, and 0.6 in Asians. Infantile hypertrophic pyloric stenosis has a male-to-female predominance of 4-5:1, with 30% of patients with infantile hypertrophic pyloric stenosis being firstborn males. The usual age of presentation is approximately 2 to 6 weeks of life. Approximately 95% of infantile hypertrophic pyloric stenosis cases are diagnosed in those aged 3 to 12 weeks. Causes. The causes of infantile hypertrophic pyloric stenosis are multifactorial. If the pregnant mother exposes to exposure to antibiotics, exposure to radiation, exposure to chemical substances, tobacco use, smoking, chewing, alcoholism, genetic factors, nitric oxide, impairment of this neuronal nitric oxide synthase, NNOS, synthesis has been implicated in infantile hypertrophic pyloric stenosis, in addition to achalasia, diabetic gastroparesis, and Hirschsprung disease. Pathophysiology. Clinical manifestations. Pyloric stenosis is rarely symptomatic during the first days of life. It has occasionally been recognized shortly after birth, but the average affected infant does not show symptoms until about the 3rd week of life. Vomiting. Classically, the infant with pyloric stenosis has non-bilious vomiting or regurgitation, which may become projectile, in as many as 70% of cases, after which the infant is still hungry. Jaundice. The infant may develop jaundice, which is corrected upon correction of the disease. Dehydration and malnutrition. As the obstruction becomes more severe, the infant begins to show signs of dehydration and malnutrition, such as poor weight gain, weight loss, marasmus, decreased urinary output, lethargy, and shock. Palpable pylorus. In as many as 60 to 80% of the infants with infantile hypertrophic pyloric stenosis, IHPS, a firm, non-tender, and mobile hard pylorus that is 1 to 2 cm in diameter, described as an olive, may be present in the right upper quadrant at the lateral edge of the rectus abdominis muscle. Gastric peristalsis. Clinicians may also observe gastric peristalsis just prior to emesis as the peristaltic waves try to overcome the obstruction. Assessment and diagnostic findings. History taking. Assess the child's history of vomiting. Ask when the vomiting started and determine the character of the vomiting. Assess for the child's elimination. Ask the caregiver about constipation and scanty urine. Physical exam. Physical exam reveals an infant who may show signs of dehydration. Obtain the infant's weight and observe skin turgor and skin condition, anterior fontanelle, temperature, apical pulse rate, irritability, lethargy, urine, lips and mucous membranes of the mouth and eyes. Observe for visible gastric peristalsis when the infant is eating. Laboratory studies. Electrolytes, pH, BUN, and creatinine levels should be obtained at the same time as intravenous access in patients with pyloric stenosis. Ultrasonography. If the clinical presentation is typical and an olive is felt, the diagnosis is almost certain. However, formal ultrasonography is still recommended to evaluate the pylorus and confirm the diagnosis. Radiography. Radiographic studies with barium swallow show an abnormal retention of barium in the stomach and increased peristalsis. CT/MRI scan. Management. Medical management. Treatment of a child with pyloric stenosis includes pre-hospital care. As with all pediatric resuscitations, pre-hospital care in patients with pyloric stenosis should be consistent with pediatric advanced life support (PALS) recommendations for infants who are dehydrated or in shock. Correction of dehydration. If significant dehydration has occurred, immediate treatment requires correction of fluid loss, electrolytes, and acid-base imbalance, starting with an initial fluid bolus, 20 ml per kilogram, of isotonic crystalloid. Diet. Feeding can be initiated 4 to 8 hours after recovery from anesthesia. Although earlier feeding has been studied, infants who are fed earlier than 4 hours do not have a worse total clinical outcome. However, they do vomit more frequently and more severely, leading to significant discomfort for the patient and anxiety for the parents. Pyloromyotomy. A surgical procedure called a pyloromyotomy, also known as a Fredericton state operation, is the treatment of choice. Pharmacologic management. Medications used to treat pyloric stenosis symptomatically are 4. Atropine. The intravenous dose of atropine for treatment of pyloric stenosis ranges in studies from 0.04 to 0.225 mg/kg and is given for 110 days. Oral atropine. Oral atropine, 0.080.45 mg/kg, is continued, after 4 therapy has been deemed successful, for 3 weeks to 4 months. Nursing management. Nursing assessment. Assess the child's history of vomiting. Ask when the vomiting started and determine the character of the vomiting. Assess for the child's elimination. Ask the caregiver about constipation and scanty urine. Physical exam. Physical exam reveals an infant who may show signs of dehydration. Obtain the infant's weight and observe skin turgor and skin condition, anterior fontanelle, temperature, apical pulse rate, irritability, lethargy, urine, lips and mucous membranes of the mouth and eyes. Observe for visible gastric peristalsis when the infant is eating. Nursing diagnosis. Imbalanced nutrition, less than body requirements related to inability to retain food. Deficient fluid volume related to frequent vomiting. Impaired oral mucous membrane related to NPO status. Risk for impaired skin integrity related to fluid and nutritional deficit. Compromised family coping related to seriousness of illness and impending surgery. Nursing care planning and goals. Improving nutrition and hydration. Maintaining mouth and skin integrity. Relieving family anxiety. Nursing interventions. Maintain adequate nutrition and fluid intake. If the infant is severely dehydrated and malnourished, rehydration with intravenous fluid and electrolytes is necessary. Feedings of formula thickened with infant cereal and fed through a large hole nipple may be given to improve nutrition. Feed the infant slowly while he or she is sitting in an infant seat or being held upright. Provide mouth care. The infant needs good mouth care as the mucous membranes of the mouth may be dry because of dehydration and omission of oral fluids before surgery. A pacifier can satisfy the baby's need for sucking because of the interruption in normal feeding and sucking habits. Promote skin integrity. The infant is repositioned, the diaper is changed, and lanolin or A&D ointment is applied to dry skin areas. Promote family coping. Include the caregivers in the preparation for surgery and explain the importance of added for fluids, the reason for ultrasonographic or barium swallow examination, and the function of the NG tube and saline lavage. Describe the surgical procedure to be performed, and explain what to expect and how long the operation will last. Evaluation. Improved nutrition and hydration. Maintained mouth and skin integrity. Relieved family anxiety.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.